All right, so part two of this spiel coming to you from Cedar Grove, Indiana. Let's talk about DKA. DKA is kind of a complex thing, especially if you don't understand it, but if you understand the basic pathophysiology, it all makes perfect sense, right? So, the general concept is that you either have some degree of insulin resistance or for whatever reason, your insulin is not metabolizing sugar. So your body freaks out and thinks that it's not going to have enough energy to metabolize and subsequently starts breaking down fat. When it breaks down fat, ketones are created, which are an acid. So, thus the term keto acids. So, the ketones are broken down and the sugar continues to go up because you have insulin resistance and the sugar's not being turned into energy. So, it just continues to rise. When that happens, much like in HHS, they develop an osmotic diuresis because their sugar is so high. While that's going on, the keto acids are driving the hydrogen ions into the cell and pushing the potassium out. Once potassium's out of the cell, it gets sucked into that flow of diuresis and they start peeing out potassium like a champ. So while it may look like their potassium's high because potassium, when you measure it, you're measuring the intracellular concentration. So when you have that transmigration of hydrogen ions into the cell, potassium comes out. So inside of the cell, the potassium is less, which is where you need it. The potassium that leaves the cell then gets peed out, and before it's peed out, it's measured extracellularly. So it looks like your potassium is high, when in reality, your potassium is low. Excuse me, Indiana allergies. So the recorded potassium is high because it's measuring the extracellular potassium right before it gets peed out. So you get these Ks of 7 and 8 when in fact they're really hypokalemic. So they pee out that potassium, the hydrogen ion goes into the cell, and they continue to be more and more hypertonic and volume depleted. So that's when you find them, whether it's in the emergency department or called to transport somebody who is in DKA. So one of the things that every hospital should do before they make the diagnosis of DKA, they either need to test beta hydroxybutyrate or serum acetone, because in the absence of acidosis and ketosis, you don't have DKA, you just have hyperglycemia. And I see that all the time. They want to admit people to the ICU because they're in DKA and their pH is normal. And that's not DKA, with one exception, and we'll talk about that here in a second. So, got to have a serum acetone or a beta hydroxybutyrate so that you know that ketones are being broken down and you actually have DKA, right? Because that's the A in DKA is acidosis. Work with me if you will. So, now you have this patient who is profoundly volume depleted, they're acidotic, and we need to talk about managing them. So the problem is not the hyperglycemia. The problem is the acidosis. Nobody died. Do you ever see somebody die from hyperglycemia? The answer is no. So don't get your underwear all wadded up about the hyperglycemia. And I see that a lot. People come into the ER and they're like, oh my God, their blood sugar is 1200. So they push insulin and hang an insulin drip before they start giving them fluids. Wrong move. Most important thing is you've got to rehydrate them to get those hydrogen ions out of the cell and restore a normal pH, or at least get their volume stores back up so that they can restore their own normal pH. So step number one is volume repletion. There's lots of times when I'm managing DKA in the ER that I don't start an insulin drip for an hour because I have other stuff going on. I just start giving them fluids. Balanced fluids are the answer. It's not clever to start normal saline, which has a pH of about 5, in a patient that is already acidotic. So start lactated ringers. What happens when you start normal saline instead of lactated ringers is all you're doing is trading their wide gap metabolic acidosis. Remember, the mnemonic is mud piles. And the D is DKA, is one of the causes of wide gap metabolic acidosis from the ketones. So, lost my train of thought because my dog is chasing my damn cat. So what happens then is you give them normal saline, and you're just trading off a wide gap metabolic acidosis for a non-gap metabolic acidosis, because hyperchloremia is one of the causes of non-gap metabolic acidosis. So not a clever approach to use lactated ringers, not a clever approach to use normal saline, use lactated ringers. No need for an insulin bolus. You can just start them on a drip, and those are really the mainstays of DKA therapy. All right, so we check all the labs because DKA always has an inciting event. Something's causing the DKA. A common cause: MIs, infection, adrenal insufficiency. Lots of things can cause DKA, but at least look for a cause: urine, blood, lungs, all causes of infection that can lead to DKA. Probably the most common cause is non-compliance, and that's patients who use that new long-acting insulin called methamphetamine instead of regular insulin. So look for drug abuse as a cause as well, or non-compliance. So the management is crystalloid fluid resuscitation, lots of it, at least 2 liters up front, and then start them on a drip of LR at 200 an hour. If they're young and they don't have systolic, or they don't have any kind of heart failure, then you can give them probably 4 liters and then put their fluids at 200 an hour. Repeat labs. You repeat lactate, BMP, check the gap, and look for their gap to continue to close and their CO2 to continue to go up. No indication for bicarb replacement in DKA unless the pH is less than 7. Don't give in. Don't get anxious. Don't give bicarb unless the pH is less than 7. If you give bicarb to somebody who's got a pH of less than 7, you're just announcing to the entire world that you don't really understand how DKA works. No bicarb unless the pH is less than 7. I think you got that part. All right, so let me check my notes here. So when the potassium gets to be, my trigger is 4.8. Some people will tell you 5. Some people will say 4.4. But when the potassium gets less than that, you got to start repleting the potassium, because you'll get behind and they can have life-threatening dysrhythmias and actually die from hypokalemia when you actually thought they were hyperkalemic. So I find oftentimes, especially in the emergency department, that the nurses come to me and the patients want to drink. And everybody gets really worked up that you can't drink. Ladies and gentlemen of the jury, there is no magic to IV fluids. PO fluids are always better than IV fluids. So they want to drink. What I always tell the nurse, I say the same thing. I say, are they still puking? No, they haven't puked since they've been here. I'm like, all right, tell them they can drink if they want, but they got to sign the contract that says they won't puke. If they start to puke, then they don't get to drink anymore. So obviously I'm being facetious, or at least I'm entertaining myself. IV fluids are not superior to PO fluids. I like when they drink, because then that tells me that I can replete their potassium PO, because PO potassium is always better than IV potassium. Why is it better, Dan? It's better because you can get a lot more of it. I can give you 40 a K now, 40 a K in an hour, and 40 a K in another hour. By my math, that's 120 milliequivalents of potassium in 2 hours. What kind of IV do you have to give 120 milliequivalents of potassium in 2 hours? ICU nurses? The answer is none. You can't give that much IV potassium to any patient. So PO is the answer. All right. When you replete K, you replete the mag. And the way you remember that is every time you give potassium, you give magnesium. ICU nurses, this one's for you. How many times have you had patients in the ICU where you just keep giving them K every damn day they're in the ICU? And you're like, why do we keep giving them K? It never comes up. You keep giving them K and it doesn't come up because you're not giving mag with it. So you give a couple grams of mag with that K, now it opens the door, lets potassium in the cell, and everybody's happy, right? All right, so PO potassium is good. Those are really the hallmarks of resuscitation of patients in DKA. More fluid. When you're not sure what to do, you give more fluid. Now, if you have somebody that's got heart failure and they're, an EF a 10 or a 15 or something, then you just have to be judicious with the fluid. Remember, if they're volume down and they're dehydrated, they can take some fluid. That doesn't mean they don't get any fluid. You just have to be a little more cautious with it and pay attention. Give them 500, take a look at them. Give 500, take a look at them. Give them 500, take a look at them. Just make sure that they're not starting to translocate that fluid to their lungs. All right, we're not going to talk too much about phosphate. We're not talking about ICU management. We're talking about pre-hospital management. So those are really the pitfalls. Insulin drip, IV fluids, PO fluids if they can take it, potassium repletion, no bicarb unless the K is less than 5, no bicarb unless the pH is less than 7. All right. Make sure you understand DKA because you're going to see it again. I promise you're going to see a complex DKA scenario in your sims. So be on it. If you have questions, send me a text, send me an email, and I'll help you to understand it. But you got to know it inside and out. You're going to see it all the time. Make sure you're down with it. Muggsy and I will check in with you later. Muggsy, where are you at? Muggsy's my pit bull, and she's chasing my cat endlessly. So that's if I seem distracted, that's why, because the cat's out here today. All right. See ya.